Hello and welcome to Temple College of Public Health's COVID-19 Beyond the Biology webinar series. The COVID-19 pandemic highlights, as never before, the importance of public health and the relevance of the college's work. We understand that health is about more than just a disease. It involves your environment, your state of mind, and your behaviors. In this series, faculty experts joined alumni leaders working on the front lines in healthcare, social services, and other organizations to discuss COVID-19 beyond the symptoms, how it impacts health, socially, emotionally, mentally, and physically. I am Mark Raymond, a proud alumnus of Temple's physical therapy program, and a member of the College of Public Health's Alumni Board of Directors. For today's segment, Life After COVID-19 and the Road to Recovery, I am joined by a panel of distinguished alumni leaders to address post-intensive care syndrome and other severe conditions that require screening, rehabilitation, and other interventions. The panelists today include Dr. Mary Sinnott. She is a professor of instruction in the Department of Health and Rehabilitation Services at Temple University's College of Public Health. Dr. Sinnott also serves as Director of Pro Bono Services and Interprofessional Education. Dr. Sinnott maintains her clinical practice at Temple University Hospital on the acute care consult service. In addition, she has lectured across the country on topics that range from the impact of pathophysiology on function to leading organizational change. We have Dr. Aimee Ring. She is Director of Rehab Services for Holy Redeemer Hospital and Transitional Care Unit in Meadowbrook, Pennsylvania. Aimee has been practicing in the clinical setting since 1995 and became a geriatric certified specialist in 2011. For the past 20 years, she has been in the acute and long care settings as a clinician and a manager. We have Dr. Kate Bruno. She is an occupational therapist and regional director of PICS Rehabilitation. Kate is also an aging in place specialist, certified dementia practitioner, and LSVT Big certified therapist. LSVT, if you'd like to know, is Lee Silverman voice treatment, and also BIG refers to the physical part of Parkinson's. We also have Dr. Jeffrey Boozin. He is a physical therapist and regional director of PICS Rehabilitation. Jeffrey is a board certified geriatric clinical specialist, certified dementia practitioner, and LSVT BIG certified therapist. We want to welcome you all and thank you for being here.
Thank you.
For the audience, if you have questions during the participation during the program, please use the question and answer function on the Zoom. So some of the overview of the topics to be discussed. In this segment, we will discuss the following: implications for the recovery of COVID-19 survivors. What is post-intensive care syndrome, known as PICS, and how does it manifest? Challenges for COVID survivors, early diagnosis and interventions, neurological, cognitive, and physical effects of COVID-19, caring for COVID-19 survivors in inpatient settings, recovery, home care, and the role of telehealth, important interprofessional collaborations, the impact of social determinants on recovery, and social implications. So now we're going to start with some questions for our panel. And we have the first question for Mary Sinnott. And the first question is, what is post-intensive care syndrome, PICS, and how does it manifest?
Post-intensive care syndrome is really an ironic consequence of someone surviving critical illness. Critical illness is actually caused by the things that are done to save someone's life. And from the standpoint of the the consequences of critical illness, there are pulmonary complications because of ventilation, and that can include diaphragmatic weakness, which I'll talk about in a minute, because especially for COVID patients, that's going to be huge. There's cardiovascular implications, and anyone that has been in the ICU and they had their blood pressure dropped, they needed to be on vasopressors or a medication to bring their blood pressure up. And that alone puts them at an independent risk for the formation of a DVT. There's damage to their renal system, their neurological function, their musculoskeletal system. They're immunocompromised. They also have a big psychiatric impact, and I'm sure that Kate can speak more about that, but the psychological impact is really quite impressive. Many of the people that are in ICU experience delirium, and delirium actually has an impact on their ability to recover. So one of the big things is to try to minimize post-intensive care syndrome is early mobilization. The consequences for post-intensive care syndrome goes on for years. This is not a quick, once and done type thing. When someone has post-intensive care syndrome, there's really three major systems that are affected. They are affected physically, they are affected cognitively, and they are affected mentally. So if we take a look at the physical manifestations, many of these people end up with what's called ICU acquired weakness. And that weakness can be profound. And the weakness is caused by what's called a critical illness myopathy, or damage directly to the muscle itself. The muscle actually starts to break down because of this cytokine storm and systemic inflammation. They can also manifest with a critical illness polyneuropathy, where there's actually a loss of sensation and there's denervation, or the most common is they have a combination of the two. So that ICU acquired weakness, on top of cognitive impairments as well as with mental status changes, is really quite impressive. Most of the people who have ICU that have post-intensive care syndrome have been ventilated. And one of the big challenges with someone that has been ventilated, and when I learned this, it was really extraordinary. If someone is on a ventilator for as little as 3 days, there's a 50% decrease in the force generation of their diaphragm. So their ability to ventilate well is one of the reasons why all of these folks that survive COVID are having such a problem with oxygenation. Many of these people are going home on supplemental oxygen at quite high dosages, and monitoring their oxygenation becomes absolutely imperative to keep them safe. So from the standpoint of post-intensive care syndrome, it results in decreases in strength, ADL performance, endurance, their ability to ambulate, and many of them have PTSD, as well as severe anxiety. The issue with post-intensive care syndrome is that survivors are 2 to 5 times more likely to die than their age-matched cohort. And the longer they're in the ICU, the worse the weakness is. So, and the weakness is quite easy to detect, with a simple manual muscle test. And once it's established, then it can really help to target the interventions that are done. The literature says that when people are 1 year out, they're still reporting difficulties with their ADL. Also at 1 year out, about 68% of them report that they have some cognitive difficulties. Someone who has been on a ventilator for more than 3 days, they report having trouble with balancing their checkbook, with reading a book, with doing their work. So when somebody survives the ICU, 1 week out from ICU, 100% of those individuals report ADL dysfunction. So they often then are going to need post-acute care. And people, especially now with COVID, people take post-intensive care syndrome with them out of the hospital. And it goes with them into rehab centers, to skilled nursing facilities, but particularly now with COVID, it's at home. So the home care community has really been challenged to deal with all of the consequences of someone surviving a critical illness and with post-intensive care syndrome. One of the things that they talk about in the literature is the issue with PTSD and anxiety, which there are individuals who 8 years out report that they still have PTSD. So there's significant impact when it comes to that. So overall, when we talk about post-intensive care syndrome, it's multifactorial. It's all of the major systems that are involved. And particularly with the COVID population, the pulmonary system is really impacted. One of the hallmarks with COVID pneumonia is this cytokine storm, and the lungs themselves scar. So people who have survived COVID and they have been ventilated literally now have a restrictive lung disease. So their lungs are smaller, they're tighter, they're harder to inflate, let alone that all of that scarring takes up the gas exchange interface. So now, even though we have myriads of air sacs in our lungs that are going to allow us to gas exchange, it's really severely restricted with this population. So especially challenging for people, especially in home care and in acute care as well, post-ICU, in rehab and in skilled nursing facilities, is how to deal with the multifactorial issues that go into place. One of the things we know, especially now with COVID, that's really quite impactful is the social determinants of health are having a huge consequence on the successful survivability, for these populations. Where do they live? Are they secure in terms of their food? Do they have a safe environment? Do they have access to healthcare? Can they get the healthcare that they need? So the challenges are really quite impressive when it comes to that. So that's post-intensive care syndrome kind of, in a bundle. It's really important to keep an eye on what their functional outcome measures are, because those are really the benchmarks that are going to help demonstrate whether or not there are improvements that are being made. And one of the things that's also heartening is that all across the country, there are popping up what are called post-intensive care clinics. The first one was at Vanderbilt in Nashville, and we're seeing more of them pop up. And I hope that we see more of them pop up, especially now, because the impact on the survivors of COVID with PICS is going to be really quite extraordinary.
So for coronavirus disease 2019, can you drill down a little bit more? What populations are most impacted and experience a longer or more challenging recovery process?
For not only for COVID, but for ICU acquired weakness as well. Hold on there, please. My bad, sorry. The elderly, people who don't have access to healthcare and have pre-existing conditions, particularly if they had a pulmonary condition like COPD, emphysema, or another restrictive disease, people with diabetes, people with significant heart disease. It's not just hypertension, it's people who have significant heart disease. And also individuals that don't have safe environments. So those individuals in particular have a much longer recovery. Now, again, that being said, the longer someone is on a ventilator, the longer their recovery is going to be. The faster they can get them off the ventilator, the less the impact of post-intensive care syndrome, ICU acquired weakness, and the less chance there is that they suffer delirium. So the particular, I can't say, so there are certain populations that are more impacted, but the critical thing to remember is the longer they're in the ICU, the longer they're on the ventilator, the longer the recovery is going to be. And what's really significant is that, other systems in the body will recover fairly quickly. But when there's neuromuscular impairment, like there is with the critical illness polyneuropathy, that can take up to 5 years for the nervous system to recover. So we're not looking at a quick turnaround. And the consequences of post-intensive care syndrome, whether it be from COVID or not, is really going to be dependent on, do they have access to the healthcare services that they need? So that's a huge public health issue that is going to have to be addressed.
Well, thank you very much, Mary. Aimee,
Thank you.
the question for you is, how is the rehabilitation staff at Holy Redeemer caring for COVID patients? And what are you seeing there?
So I think what is interesting is that we absolutely have a population that is in the ICU, people that are on ventilators. But the interesting thing that happens is that there's this whole population that comes in that has COVID as a diagnosis. But what we have found is that's not their primary diagnosis. We've had patients who've come in with exacerbations of COPD, who's had a CVA, who has some kind of like a cardiac issue. So now that person's coming in with that issue and has COVID. So as most hospitals, we have COVID units. And one of the really big challenges in the acute care hospital is that it's not our norm. It's not our usual thing. We have to take our regular techniques and we have to adapt them. So now we're in a hospital room with a patient and there is a HEPA filter. You know, we have on N95s and face shields and gowns and everything. So it's an interesting perspective because it's not only the patient that is having sensory deficits, the therapist is having sensory deficits. So, you know, traditionally we're going in, we're utilizing therapeutic exercise and everything. And then it becomes the challenges. And now we have this patient who, as Mary points out, has all these respiratory issues, all these issues with their lungs and everything. Traditionally, we're getting this person up, we're standing them, we're trying to walk with them, we're trying to increase their endurance. And we are now in a room that is this tiny room that has multiple IV things, you know, oxygen tubing, all these challenges and stuff. And it's like, how do we accomplish this? So there's been a lot of creativity, a lot of focus, I would say, on like what we traditionally learn as therapists regarding exercises. The other challenge is that in the beginning, we were really hopeful that, you know, if we had patients who were cognitively doing okay, that were fairly independent, you know, we could give them almost like a home exercise program in their hospital room and they would be able to continue it. And we found that that wasn't really the case the majority of the time. You know, that we were dealing with patients who had come from ICU, who just had very debilitating secondary diagnoses, and really the only movement they were having is when the therapist was coming in the room. So a lot of, you know, just sitting, trying to work on core and things like that. The other interesting thing is different techniques have come up though, you know, the whole information that you hear about proning techniques, you know, and I will say that I work at a community hospital. We're a 240 bed hospital. We have a 20 bed ICU. So we're not your large, you know, trauma center who has multiple ICUs. So we didn't have proning teams or things like that, but I will say that we had 2 patients in ICU who were on ventilators for at least 35 days that, you know, the intensivists, the therapists, the nurses are like, what are we going to do? Like, how can we, you know, work with these patients? So proning is actually basically having the patient lie on their stomach. You know, we have to change their position. So if we can put someone in that position, you know, supported appropriately, we can kind of give their lungs a break. I mean, Mary can probably explain proning way better, but I mean, that's kind of the gist of what it is. So it takes that pressure so you actually hopefully can get that air exchange to be better. And
well, thank you. There's a follow-up question for that I guess both that for you, Aimee, is how effective has proning been in your practice?
It actually, for the 2 people we did it, it worked well. And what we have found is that someone doesn't have to be ventilated in order to benefit from proning. I mean, if you have anyone who has any kind of underlying respiratory issue or anything, we have found that if we could just get them to go onto their bellies for a while, their oxygen levels would improve.
Mary, do you want to piggyback on that since we're referred to you?
The reason why proning works is, well, first of all, the best position for the lung is an upright lung. But these people are on ventilators, they're in the ICU, and if you can't get them up, proning is the very next best thing. The reason why proning works is that when you're lying on your back, when you're lying supine, the weight of your heart is on your left lung, and all of your alveoli, the air sacs on the back of your lungs, are more compressed just because of gravity. And the surface area for gas exchange is much larger on the back of the lung than it is on the front of the lung. So when you actually put someone on their stomach or you put them into prone, number one, the weight of the heart goes onto their sternum. So the weight of the heart is off the lung, and all of those, all the alveoli posteriorly can just open up so much more. So actually putting someone on their belly gives you more gas exchange surface area. So oftentimes what will happen is they'll spend, they might spend 4 hours supine, 4 hours prone, 4 hours supine, 4 hours prone, back and forth. And they found that particularly with people who were on ventilators for under 28 days, they significantly improved. After 28 days, they didn't have as much success with it, although in prone, their oxygenation did increase.
Okay, great. So now we're going to move to Kate for the next question. And Kate, reports suggest that coronavirus can directly infect the nervous system in some people. What are some of the neurological effects of COVID-19 post-disease and implications for recovery?
Sure. So as you can see, kind of a general theme is we're still learning about the effects of COVID and how that changes our approach to the rehabilitation process and our role as the professionals in that process in returning our patients to their prior levels of function. And the literature right now is showing that there are potentially multiple neurological concerns that patients with COVID have. And these can include dizziness, headache, nausea, vomiting, long-term loss of smell, as well as changes to the medulla that alter brain function. And one of the challenges that we have in the future, and Mary touched on it, is learning what these long-term effects are going to look like and what these neurologic long-term effects are going to look like, so that we as clinicians can meet the needs of the population. And obviously it presents differently in different groups of people, different populations. And as expected, these neurological effects can lead to a need for increased time for the rehabilitation process, as well as creativity in the way that we approach care. So in addition to the significant increased fatigue and decreased endurance and the tendency for these patients to decrease in their oxygen saturation, these neuro concerns can lead to a tolerance of only shorter sessions or shorter bouts of exercise. And Aimee touched on that we're able to do much less than we would normally think we would be able to do. And these need for shorter sessions can lead to a longer plan of care over months or years, depending on the severity of the case. And as an occupational therapist, these neuro concerns have a significant effect on the ability of my patients to participate in those basic ADLs, such as bathing, dressing, transfers, toileting, grooming, and bed mobility, because I can only work on them in very short periods. So for somebody who maybe I would want to do a full ADL with, I may only be able to get them out of bed and do upper body dressing because of the neurological concerns that are present.
So that was a great explanation of some of the physical effects you see. How about the cognitive implications on of the effects of COVID-19 on the patients that you see?
It plays such a huge role, and Mary touched on it from a PICS perspective, that these are long-term concerns from a cognitive perspective. And these cognitive impairments can present in a higher level cognitive function, so looking at attention and problem solving and organizational thought, as well as the delirium, hallucinations, and decreased concentration that Mary spoke on. And this can raise huge concerns about a patient's ability to return to independence, because it can impair their abilities with valued occupations. So those basic ADLs that I spoke about, but especially as an occupational therapist, looking at those higher level IADLs. And those can include money management, medication management, meal preparation, home management, and potentially return to work if that's appropriate to the patient. And this presence of the cognitive impairments alters my approach as an OT, because I have to ensure that in every single session, I'm integrating some sort of cognitive approach to what I'm doing. So keeping that in mind as I build my treatment sessions and as I work with my patients. Specifically in our model with Fox, a lot of times I'm referring to my SLP counterparts. So that way we're hitting it from multiple angles, and we're able to really look at a multidisciplinary approach to our care, because without each person in the team, we're not going to be able to reach the maximum benefits that we could potentially do. So with our physical therapists working on the endurance and gait and transfers and getting them up and moving, myself working on those ADLs and IADLs, and my SLP counterparts concentrating on the cognition, we're able to give them the best chance of success and returning to that prior level of function, because without that intact cognition, there's a high probability that they won't be able to maintain independence or get to that prior level to be able to return to their normal daily life.
Great, thanks so much.
Mark, if I may, just to Kate,
Yes, please.
explain SLP, please.
Sure. So SLP is your speech language pathologist, and they don't just do swallowing and speech production, but they can also work on cognition and work hand in hand with OTs so that we can, and PTs so that we can get people back to that full picture of function.
Thanks very much. Yep. Jeff, can you walk us through some of the physical effects of COVID-19 post-disease and the implications for rehabilitation and recovery?
Yeah, absolutely. Patients that are post-COVID present with a variety of physical effects based on the severity of the infection and their underlying health issues. Some of the most common physical effects we're seeing, and Mary already touched on, we're seeing cardiopulmonary, heart and lung function, circulatory issues, and most profoundly musculoskeletal and neuromuscular issues. So some of the things that I'm seeing in daily practice, we're seeing a higher prevalence of myocarditis, which is inflammation of the heart tissue. We're seeing a higher prevalence of heart failure or advancements in heart failure in those folks that are affected by that. As far as the lung function, we're seeing decreased lung volume and difficulty with respiration and ventilation. Obviously, that's impacting a person's ability to participate in their daily functions, their overall endurance. We're seeing an increased presence and prevalence of blood clots and DVTs, which Mary also touched on, and just profound large muscle group muscle atrophy, especially for the longer duration that they're in the intensive care unit. These changes, along with others that are being discovered during clinical trials, have led to a higher prevalence of a medically complex, severely deconditioned patient returning primarily to their home environment. And the implications of rehab are profound, as the multi-system impact of COVID has yet to be completely determined, which really dictates the need that now more than ever, we're treating our patients in a completely holistic manner as therapists. And in doing so, we can ensure that we're addressing the underlying physiological concerns and changes by COVID in order to assist the recovery of our patients.
And a follow-up question, what are some of the rehab implications of COVID-positive patients post-discharge?
Yeah, post-discharge from the hospital, what we're seeing is there's an increased number of patients returning directly home from these COVID hospitalizations. And again, as I said, they're in a much more debilitated state, especially those that have had PICS in addition to COVID. As many of the skilled nursing facilities aren't accepting COVID-positive patients at this time, or if they are, they're very limited in their capacity, and they're limited based on room quarantines. Traditionally, the added rehabilitation that you would get either in acute rehab or a subacute rehab or skilled nursing facility would help address a lot of the physical deficits and put patients in a much better position moving back into their home environment as the result of that post-intensive care syndrome. But the limitations in rehab participation due to the quarantines and the restrictions in all facilities really demonstrate the benefit of a discharge to the home environment. Utilizing the patient's home allows the opportunity for a rehab program to be performed in a much less institutionalized setting, which we can then focus more on task-specific training and function within that person's environment. It also allows a reintroduction of previously established social supports. So examples of that would be family members living in the home, or even interactions with peers and neighbors through appropriate social distancing practices, which again, when we're seeing these cognitive changes and the psychiatric changes, it can kind of help mitigate some of the depressive symptoms, which again, if we're addressing depression, we're addressing a person's willingness to participate in a plan of care and their adherence to their home program, which can drastically improve the rate of recovery.
Okay, there are two questions, and they're for Kate and Jeff, and you guys can decide how you want to answer this. So I'll give you both questions. Home care, how are COVID survivors presenting at home, and has your care management strategies changed? If so, how? And is your organization using telehealth?
Sure. So I'll start. And as with anything related to COVID, the survivors are presenting at many different levels upon their return to home. So I've seen minor cases where we can kind of take more of a, for lack of a better term, traditional approach, where we're not seeing as many of these neurological issues or cognitive changes. But in other cases, we have to significantly alter our approach. And again, utilizing shorter sessions or less difficult tasks initially, and then moving to longer sessions and more cognitively taxing tasks later in our plan of care. And this change in our approach, along with the respiratory and endurance challenges that our patients could exhibit, can lead to a slower progression in a plan of care. And that's something that as clinicians, we need to be aware of and prepared for, and be creative in how we build our programs to work around that. And as an occupational therapist, and this ties directly into what Aimee was saying about our thought of utilizing an HEP to get people up and moving faster, because we can't do as much. So one thing that I've really done is involve any caregivers or family members in my very first session. And as an OT, I would always include them in my plan of care. But I am making a significant attempt to make sure that somebody is with me in the initial evaluation, so that I can make recommendations to ensure that their family member or the patient is able to successfully complete their ADL tasks safely, with any modifications or changes that I need to put in place to make sure that when I'm not there, that they are safe and able to take care of it. And then also just I'm making more home modifications than I used to. So instead of taking more of a complete rehabilitative approach in the beginning, I'm combining a rehabilitative approach with a modification approach to make sure that I'm keeping my patients safe with those ADLs and IADLs. And utilizing those compensatory strategies to make sure that they are able to do what they need to do. Jeff, do you want to touch on it from a PT perspective?
Sure. So kind of in parallel, we're utilizing a lot of caregiver education, and similar to what Aimee brought up is tagging in and utilizing the caregivers or family members to provide more of that home exercise program. We're focusing a lot on basic endurance training, and a lot of the cardiopulmonary issues we're seeing that are affecting lung volume, lung capacity, tidal volume, ability to take deep breaths, essentially using the diaphragm, education to both the patients, their caregivers, their family members on the importance of both diaphragmatic breathing, which is that deeper respiration, which will help with lung expansion, focusing on making sure the patients are utilizing that during their everyday mobility, let alone or outside of their rehabilitation program. A lot of what we've seen is that interdisciplinary communication that Kate was touching on with our speech language pathology counterparts, our OT counterparts. And I've seen coming out of this that physicians in their primary care practices are much more willing to jump on the phone and have a conversation with the clinician that's in the field with their patient, describing to them, what is going on the day-to-day, in order to have that more full team approach, which is great. And the biggest thing that I've been a proponent of since my days at Temple is practicing at the top of your license. So utilizing everything we can within our scope of practice to make sure we're providing the best medical care and rehabilitative care in that home environment.
Anybody, the telehealth question, did we really go into that yet or no?
So we have the ability and we are approved to utilize telehealth as outpatient providers. In our practice model, we prefer to be hands-on and in front of our patient, for obvious reasons. But we are looking at utilizing a hybrid telehealth approach where we're partially with our patients in their homes, partially doing telehealth if we feel that it's appropriate. We haven't been doing a ton of it just because we do feel that our skill is needed when we're in front of our patients from so many different perspectives, and really practicing at the top of our license, as Jeff said, and having those intelligent conversations with our physician counterparts and the family members. So we feel that there's nothing obviously that replaces that in-person interaction. So we have the ability to use telehealth, but I know I haven't used it a ton, and I believe that Jeff's team hasn't as well, just because we want to continue to have that in-person interaction as much as humanly possible.
Correct. Yeah, we're more so using it as an educational tool for family members and patients as needed. But again, that hands-on and being able to appropriately dose exercise and make sure that people are getting that moderate intensity to be able to rebound from a cardiopulmonary standpoint is important, and that's something we really can't do from a telehealth perspective. So that's why we're utilizing that hybrid approach that Kate had mentioned.
And Mark, if I can jump in just real
Yes,
quickly, telehealth is here to stay, is what we've learned in rehabilitation care. However, the situations that Kate and Jeff are describing, these people are still too impaired to use telehealth. You have to have a certain level of medical and functional stability to use telehealth exclusively, except for education, as Jeff was saying. So particularly when they first go home, it would not be safe to do telehealth, with these people, because their functional impairments are so profound. Thanks.
Yeah. Okay, well, this question I'll ask Aimee to answer first, and then she can talk to Kate and Jeff collaboratively about the answer on their end. So coronavirus has sparked new industry collaborations in a team-based care model. Can you share some new or unique interprofessional collaborations and models your practice has adopted?
So I have to say that in an acute care setting, we always have a team approach, but I would say that the whole COVID-19 crisis has kind of honed that. So now that we're entering rooms that patients are on a quarantine, rather than just going to the nurse and saying, hey, is it okay if we see this patient? Now the conversation is that, okay, who do you have on who do we have on your caseload? What can we do to kind of minimize and work together to treat this patient? So the nurses are coming in with us more things are being done. So to Kate with the ADLs, we may go in with a nurse and they're like, I need to change, bathe, some type of medication, a positioning issue. So we really get that interdisciplinary connection, which has been there, but I have to say it's much more enhanced. And from a professional standpoint, I will say that all the years that I've been a therapist, though, I think a very positive thing about COVID might be this could actually be kind of the stepping stone for people to really realize what our skill set is. As Jeff said, that we really try to work at the top of our license. And I mean, there's just always been kind of a stigmatism that, therapists walk people and things of that nature. So I think the fact that multidisciplinaries, like we're working with the respiratory therapists, the nurses, the physicians are getting in the room with us. And I think that they're almost a little surprised, even though we're advocates, that, hey, it has caused other relationships to develop and other referrals to occur.
I agree completely. And as soon as you were talking about this, I was thinking about literally a session I had 2 hours ago, where a very similar thing happened, where I a lot of times get the stigma of, oh, you're an OT, you just dress people. And I had a really good conversation with a member of a care staff in a senior living community about some techniques that they can utilize to get a patient to participate more post-COVID. And when we walked out of there, you could tell there was just a better collaboration and a better relationship there. And we're seeing that, as Jeff touched on, with physicians, and calling and having that intelligent conversation of, I'm in the patient's home, they are presenting X, Y, and Z, their vitals are this, they are 3 weeks post-COVID. And having that conversation has really brought a lot more respect to our fields, and has helped to strengthen the bonds with the physicians that we work with, specifically in a house call setting, because we rely so heavily on that communication, because we don't work in the same building with the physicians that refer to us. So being able to show the benefit of that collaboration and our ability to help keep their patients out of the hospital, I think is really a strength that is going to come out of this COVID pandemic as a healthcare field.
Okay, thank you. So now we're going to go to any speaker that would like to answer the question. So the first one is, how do social determinants of health impact recovery? And just chime in and talk amongst yourselves.
Well, I would say that part of the issue is that the social determinants have always been an issue. I mean, we've always, especially just as the time I've spent, you know, in the therapy world, is more and more like dispositions are issues when we go to discharge people, just about family support and are they able to get their groceries and things of this. So it's kind of been there. And then the whole COVID crisis has taken us to a whole new level, because now you have people who are quarantined and you have that, you know, stigma that, oh, you had COVID. So, you know, what services are available, who's willing to assist and things like that. And as Mary said, this isn't something that's like, you know, going to go away. One, I mean, I think COVID's going to be here for however long, but the effects of patients who have had all this, and what is the sustainability of making sure that they're okay as they recover?
You know, I think one of the other things that impacts on it from a social determinants perspective is the individual's literacy, and not just their general literacy, but their health literacy. And a lot has happened to these people, and trying to get them to, trying to help them understand what it is that has happened, and, you know, how they, what they need to do to take care of themselves in language that is translatable for them. Because if you look at the populations that were disproportionately impacted, that there are some, you know, socioeconomic issues, and that can certainly impact on their literacy. And health literacy becomes even more a higher priority. And oftentimes, you know, that falls to, you know, OT and PT. I'm sure all of you have had this experience where you'll go in to see a patient, or they have just been to see a physician, and you know, you go in after they've talked to the physician, or the physician's been in the room, and they'll say, "Can you explain to me what they just said?" I mean, you know, that happens all the time. So one of the benefits I think that we have as rehab professionals is we have the time. You know, we get to know the patient better, and we have the time to really listen to, do they understand what is happening to them, and find a way to explain it. And sometimes it, you know, it's a simple metaphor, you know, that you can use, but if it's one that they get, you know, then, you know, you're better off. I mean, we had a 52-year-old man come into the pro bono center, and he was a line cook, and he had a stroke secondary to undiagnosed hypertension. Why did he have undiagnosed hypertension? Well, he didn't have any health insurance. So he came to the pro bono center, and he said, you know, they told me I have a stroke. What does that mean? And we just said to him, well, if you think about your brains like a transformer and you blew a fuse, he goes, okay, got it. You know, and it can be just something that simple to make sure, you know, that they get it. So that's one of the concerns, you know, that I have a particular emphasis on, is we need to be able to, we are translators between the medical jargon, if you will, and what people understand in their everyday lives. And I think rehab professionals are uniquely educated to do that. Thanks.
Okay, great, yeah. So what the next question is, what are some of the societal implications? For example, tracking and figuring out how COVID-19 affects the body, even after recovery, could inform government's budgeting for social safety nets, doctors that see patients long-term, and businesses as they set policies such as sick and disability leave. These issues could be even more crucial as public health officials say there's a possibility the virus may become a seasonal affliction. Economies and companies looking to get people back to work will need to understand how and if COVID-19 affects human health in the long run and its scopes. What do you guys think?
I think a lot of it comes down to what Mary was saying in that education. So us as a society better understanding what it means, what COVID-19 means to us in each of our roles. And that's where we as clinicians can really play a unique role in, like I'm thinking about a family that I worked with, nobody had tested positive for COVID, but educating them on, okay, these are the precautions that you need to take from a hand hygiene perspective, from a mask perspective, from a quarantine perspective, social distancing, and we can play that role as kind of that translator. But I do think the key to a lot of this from a therapy perspective is going to be education and the positive things that we can do to help our patients understand that.
Another question. Go ahead. Sorry.
I was just going to say, and Kate, you and I were talking about this the other day, is I think that what has happened with the whole COVID pandemic will really uncover the real crisis of health insurance coverage. Kate, you were telling me about, with a Medicare patient,
Yes.
and kind of the restrictions that you have. And I think it's a really good illustration that we really need a rework on this, because people without access to the care that they need will be out of the workforce a heck of a lot longer, and their costs are going to be much, much higher.
Yes, and specifically in the Philadelphia market, Fox is primarily as a whole, as a practice, is a Medicare Part B model, but we also partner with Medicare Part A companies to provide services to people throughout the city and throughout the continuum of care. And one of the things that we've seen with the recent changes to Medicare, and a lot of PPOs and HMOs follow suit, is that they are watching utilization much more closely than they ever have been, which can become a problem when somebody is coming out of the hospital as a COVID survivor and they need those longer durations of care. And maybe we would only have access to a specific number of visits. And again, this is both Medicare and insurance. Sometimes we're given 8 visits in a 30-day period, and that's it. So then we as clinicians become creative to make sure that we're meeting the needs of our patients. But it does speak to the overhaul that I agree we need to have in the healthcare system to make sure that people are receiving the care that they truly need, especially in a post-COVID world.
So looking forward, in what ways can healthcare professionals and clinicians mitigate the negative effects and the impacts on survivors and improve recovery outcomes?
So I think a lot of that comes into play with, I touched on earlier, like the holistic approach of the patient, right? So many specialty groups focus just on their one primary goal of like, let's fix this issue and let's ignore the rest of the body. That's not the way we can approach a person, a patient, a human being, especially with knowledge of what COVID-19 is doing to the body as a full system. We have to work in better interdisciplinary teams outside of therapy, with specialty subgroups, and just again, like working on the education, treating people in a holistic manner, and just improving communication across the disciplines, the physician groups, the rehabs, will help.
Okay.
I think one of the things too that we need to do as healthcare practitioners is that we have to be advocates. We have to be advocates. I'll give you the example of telehealth. Once the pandemic calms down, the Medicare waiver for rehab professionals to do telehealth will go away. And that is also true in the state of Pennsylvania. Having the ability to practice using telehealth as a modality really helps us practice at the top of our license. And with access to telehealth, you're able to help someone in their extended recovery better, because literally you can do a house call and see how they're doing in their own environment, once they get to that certain point. So I think advocating for things like telehealth, advocating for things like, health insurance, coverage, and making sure that habilitation and rehabilitation services stay part of the essential health benefit. With what other reform, may come, or whatever next iteration there is of, say, the Affordable Care Act, and also in individual insurance plans, because these people will not recover to the degree that they could without rehabilitation services. And, we've been fighting insurance restrictions, for years. One of the things too, I think we need to advocate for is that the whole issue of copays, get into a realm where people can afford it. If these people go home and then into outpatient and they've got a $50 copay, and they are severely debilitated, they literally cannot afford to get better.
And I think, Mary, to your point too, is we need to advocate, but we also need to teach our patients to advocate for themselves also, which I think is a really big point, because, kind of working in both like the inpatient and outpatient world, is that it's amazing that when the patient picks up the phone and contacts their insurance company and kind of raises a stink, it's amazing how wheels will turn. So, I mean, it would be fabulous if multiple people actually took that on themselves to say that, hey, you know, this is what's going on, this is what's happening, and I need it. I mean, I think that combination of us as the professional and our patients advocating for the same thing will be the best way to actually have change. Because, you know, it's really interesting. I was thinking about this as we were talking, is that, you know, are they going to have COVID-19 as a pre-existing condition on health benefits? I mean, wouldn't that be an interesting thing? And then just because of the longevity of the symptoms and things. So I think there's a lot for that.
Okay, well, thank you. There's a question in the Q&A. Is the lung scarring only in ventilated patients, or does it also happen with milder cases?
Well, it can happen in milder cases because what happens in the lung is this cytokine storm that causes all of this acute inflammation, and it's the inflammation that causes the scarring. Now, the milder the case, the less the scarring. There's, you know, wonderful redundancy in the lung that allows people to live with one lung. It allows people to live with pulmonary disease. So there will be scarring. If it's a mild enough case, the scarring will be absolutely minimal, and they're not going to have an oxygen challenge.
Okay, thank you. We have an opportunity now for any live questions. So do any of the participants want to ask a live question? I see, what type of early interventions are important for ensuring patients' full recovery?
Aimee, do you want to start with that?
Sure. So I really think that kind of going to the basics and, you know, utilizing what people have. So actually, like, utilizing a spirometer. You know, it sounds like such a simple thing, but how do you exercise the lung that's already compromised? So I think using that kind of intervention early on, and to actually get the patient moving. I mean, if they can tolerate sitting on the bed, sit them on the bed. If you can stand and do exercises, do that. If you can walk, like in the acute care setting around the room, walk. It's all about getting that mobility, because they are just overall so deconditioned that even getting up to go to the bathroom is like a huge challenge. So I would say it's really just starting whatever they can do, and track it. You know, I think that if patients kept a journal and could see what their progress is, and how they're doing and how they're progressing, I think that also helps at a lot of other levels too.
You know, one of the things that, you know, it's more restricted now, but if someone's in the ICU and they're on a ventilator, you work with the rest of the team to get, you know, what's called a sedation vacation. And you get them up, and it takes a village. It takes OT, PT, nursing, respiratory therapists, and you could walk those individuals around the ICU and keep them up and keep them moving. And one of the things that the literature is very clear on is the earlier you mobilize somebody, ventilated or not, the less impact there is on ICU-acquired weakness, and the less intense is the post-intensive care syndrome. With this population, though, because of the environmental restrictions, because of quarantine, you can't do that. So these people are almost guaranteed to have a longer recovery because we couldn't do the prevention that we normally would do.
Great, thank you. Josh, do you want to put up the fourth slide and then the fifth slide?
Mark, before he does it, I
Sorry.
forgot to mention something that I think is important. And, you know, Jeff brought it up that we're seeing these people, you know, with a lot of DVTs. One of the unique things that COVID does is it attacks the clotting cascade, which is why you're seeing these people. Another thing that complicates the restrictive lung disease is that, you know, they did autopsies on people who died from COVID, and their lungs were full of blood clots. There are also people that have lost extremities and lost digits because they have, you know, thrown blood clots, arterial blood clots, you know, to their fingers and to their toes. And there's one gentleman who's an actor who actually ended up with a transtibial amputation because his foot became necrotic because of that clotting impairment. Now, I think it was yesterday or the day before, a research team at Oxford University, they discovered that if they treat people with dexamethasone, that their recovery improved significantly. So, you know, as you said, Kate, you know, we don't know, and this is all really evolving. So the more we can contain the inflammation and the cytokine storm, the less consequence there's going to be. But we still have to be on the lookout for clotting impairments. Thanks.
Okay, great. So what we'd like to say to all the audience participants is that COVID-19 highlights as never before the importance of public health and the relevance of our work. To access a recording of this segment, as well as all previous Beyond the Biology webinars, you can go to the website, cph.temple.edu/COVID-beyond. And something that's really important during this time of the pandemic is supporting the students in the College of Public Health. And to do so, you can visit the Secure Giving page at cph.temple.edu/giving, or you can contact Natasha DeLuna directly, who is our Chief Development Officer and a great person to have with us in the College of Public Health. So stay up to date on the pandemic through the college's coronavirus resource page, which includes faculty expertise about preventive measures, disease transmission, and the status of the outbreak from a public health perspective. And I want to say a personal thanks to all of the participants. Temple University is in great shape having you all affiliated with it. And thank you all very much for being graduates, alumni, and participating today. And to everybody in the audience, thank you, goodbye, and remember Temple University, and have a great day. Bye-bye.